I'm Stephanie Costa. I'm one of the EMS fellows for the current 2023-2024 year, and I'm going to talk to you about pre-hospital diagnoses and pre-hospital care. So we will be talking about the importance of differential diagnoses and anchoring bias, and then we'll take a deeper dive into the differential diagnosis of altered mental status, chest pain, and respiratory distress, and then lastly back pain. So, differential diagnoses. Why are they important? We form differential diagnoses to make sure that we are appropriately assessing and caring for each patient. Also, as pre-hospital providers, we're basically the eyes and the ears of the hospital. So if we don't notice something or relay the information of how a patient was found, where they were found, concerning findings, then information may not be passed on properly. It's also really important because if you have a suspicion that somebody may need more care and that you may have to call for extra help or ALS, it's also very important to find those details and then call for that appropriate help. So let's talk about anchoring bias. Anchoring bias is when you take a single piece of information and then base every single thought, action, decision on that, instead of taking in more information and maybe thinking more broadly about a problem. So for example, that could be our frequent flyers who call 911 very often. It could be patients who struggle with substance use. It could be agitated patients where you see them, you know, they may call every day and you kind of just write off them calling instead of looking for deeper causes as to why they're calling or if they're having a medical issue. Patients with substance use, you may only see their substance use, not that maybe they had a trauma recently, they fell, they hit their head, maybe they're having a medical issue at that time, and maybe agitated patients may have hypoxia, they may be having another medical issue. So it's important to think past what you initially see or that initial piece of information that you get and really be a good clinician and gather the history and the physical to best care for your patient. So this is just a mnemonic that I used in medical school, but it's just a way that I'm going to use to really be able to organize our differential diagnosis during this lecture. I don't expect you to do this for every single patient that you guys see, but just as a way for organizational tool for this lecture, just want to go through it. So let's first talk about altered mental status. So what information should you ask? And then what's your differential diagnosis? So some of the information that you should ask would be a basic history, any events leading up to the altered mental status, when they're last known normal. Is this a mental status change that's been ongoing for months or years, or did it just happen? Did something recently just happen and now they're altered? So a good timeline is very important. Any recent events, new medications, recent procedures, trauma, substance use, any information that you can gather will be helpful and also may help you take a better look at your patient and also call for services if you need them. So let's look at some pitfalls and then some serious diagnoses of altered mental status. So I think a common pitfall may be that they're just on the older side, where, oh, well, they're altered because they're of advanced age. But we need to really figure out what their baseline is. If they're normally able to take care of themselves every day, but now all of a sudden can't, that's very concerning. A very common pitfall is, oh, they're just always like this. You need good information to make sure what their true baseline is and if they're having any differences in how they function. Common pitfalls are they're having some sort of emotional event or they're just anxious. However, a lot of medical conditions cause anxiety. Your body knows when something's not right with your heart or with your brain, and that can manifest as anxiety. How about they're just intoxicated? That's a dangerous pitfall where blaming an altered mental status on intoxication is not good for the patient. Sure, they may have a substance on board, but that potentially leads them to having those falls, having other issues happen to them. So you need to have a higher level of suspicion that there could be something medically wrong. Because what happens if that patient actually has an infection in their brain, like encephalitis? What happens if that patient's actually having an aneurysm? What if that patient's having a stroke? Not all strokes manifest as one-sided weakness. They can manifest in many different ways. What happens if they have metastatic cancer and now the mass in their brain is bleeding or there's swelling? What happens if they fell and now their brain's trying to herniate from all the blood? So we need to have a good differential diagnosis and a high level of suspicion to make sure that we're appropriately taking care of our patients. So here's a limited differential diagnosis for altered mental status. So we talked about some of the vascular causes of stroke or aneurysm, etc., infectious causes, neoplastic or more cancer causes, degenerative causes, where a timeline would really help you with that. Iatrogenic, which means secondary to the medical field, like if they're on new medications or they're having a drug interaction or they're having a side effect from a procedure. If there's substance issues, either intoxication or withdrawal can cause altered mental status. If they have a condition that they were born with that is prone to some sort of disruption in their brain or how they function. If they have an autoimmune condition, a lot of autoimmune conditions and their medical management make patients more susceptible to infections and vascular injuries. If they have a blood sugar problem, if they had just a traumatic event, if they have electrolyte abnormalities, if they have high ammonia, or if they have acid-base disturbances. This and many, many more can cause altered mental status. So we want to get a good timeline of symptoms. Is this an acute change or is this a chronic change? Has this been progressively happening slowly, or is this very quick and new onset? Did they have a recent trauma, new anticoagulation use? Did anything happen? Is there a new diet or psychosocial stressors or chronic medical conditions that may have just gotten worse? Do they have any past medical or surgical history? What medications do they take? And this doesn't always only help with you getting a history, but it also helps potentially helping elicit more medical history out of a patient. They may forget about a medical condition, but if you ask what the medication that they're taking is for, you may get more medical history that way. Always want to ask about allergies and substance use, either intoxication or withdrawal. And then you want to do a good exam. Is your patient awake? Are their ABCs intact? Any trauma or any findings on their head or neck? How about their heart and lungs? What about their belly? Are their extremities okay? Do you see any signs of trauma? Is there anything that you need to intervene upon? Is there anything that you need to call ALS for or medical command? Or are you okay to transport? These are all things that you need to take into account and make sure that you're moving your patients along appropriately and getting the appropriate level of care for them. So now we're going to look at chest pain. With what information should you ask, and what's your differential diagnosis? This is where you can take your sample history or the history that we spoke about above, but you definitely need to know when it started, where's that pain, where's it radiating to, does anything make it better or worse, do they have a history of cardiac issues? There's a lot of history that you can take there. And then let's start thinking about your differential diagnosis. So a common pitfall is it's just musculoskeletal pain, but it may be cardiac. Even if you have reproducible pain on exam, it can still be cardiac. It's just their acid reflux. It can still be cardiac. A common pitfall is anxiety. If your heart is in trouble and you're having a heart attack, you're most likely also going to be anxious. Your body knows that something is wrong. Your heart tissue itself can be infected. You could be having an arrhythmia that's affecting perfusion to your heart and to your brain and to the rest of your body. You could be having a dissection that's altering blood flow. You could have blood around your heart causing a tamponade. Could be having a heart attack. The important thing is to remember is that you only have one heart. So we need to have a very high suspicion of cardiac events and let any of those cardiac events be ruled out at the hospital. I cannot say that somebody is having a cardiac event or not until I've gotten back further testing in the ER. And sometimes I have to admit patients for further testing too. So have a high suspicion that there is something cardiac going on when somebody is complaining of chest pain. So going through the differential is pretty wide. This is not completely inclusive differential, but again, listing things through. These are just some of them. So in chest pain, we still want to ask those timelines of symptoms. We want to ask about all the events surrounding the onset, their past medical and surgical history. Do they have a cardiac history? Do they have coronary artery disease? Have they had prior heart attacks? Have they had a history of a bypass surgery? Do they have diabetes? Do they have high blood pressure? Do they have high cholesterol? A lot of these things increase your risk for cardiac disease. And even if maybe they don't remember that they have cardiac conditions, if you see aspirin or nitroglycerin, if you see them on a statin like a atorvastatin or pravastatin, if you see them on metformin or insulin, pointing more towards like a diabetes history, if you see them on Entresto for heart failure, etc., a lot of these medications can point you towards them having a cardiac issue or potentially the comorbidities that put them at higher risk for having a cardiac incident. And again, always ask about their allergies, substance use. A lot of substance use like cocaine can increase your risk of a cardiac event. And then you want to do a good exam again. You may not see any exam findings on somebody with chest pain and an acute cardiac event, or you may see some JVD, you may see lower extremity edema, you may have some heart or lung findings, you may have abnormal pulses, but you also may not have any significant exam findings. So always keep that chest pain with a high level of suspicion for something being cardiac. And moving on to respiratory difficulty. What information should you ask and what is your differential diagnosis? Before we move on to the next slide, I just wanted to touch on the fact that your heart and lungs are very much connected. So the differential diagnosis may sound similar with the understanding that even if somebody's complaining of shortness of breath, that could be an underlying cardiac etiology. So going through from the most benign to the more scary would be somebody maybe just has a viral illness or bronchitis. Maybe they have pneumonia and that's why they're having trouble breathing. However, they could have an esophageal rupture if they were vomiting and had a recent GI bug. They could have a cardiac valve dysfunction that's leading to fluid buildup in maybe just one of their lungs. They could have a history of pulmonary fibrosis and now are fluid overloaded or could have worsening of their chronic disease. They could also have a heart attack. So it's very important to really just understand that the cardiac and pulmonary system are very interdependent. So lung issues may be due to cardiac issues and vice versa. So going through here's just an example of some more differential diagnoses that could present as respiratory distress. So we want to take that same good history with all of the timelines, events, past medical and surgical history, medications, allergies, substance use. And with substance use and anybody with respiratory issues or anything that's really just doesn't seem congruent with the history that you're getting, you can always ask about possible chemical exposures, sick contacts. Do they work in an industry where they could have gotten some sort of contamination on them? So also just the events surrounding the respiratory illness may also be helpful, especially if things aren't really lining up. On exam, do a great exam. with their level of responsiveness, ABCs, taking a good look at their head and neck. Is the reason why they're in respiratory distress because they have an upper airway obstruction, possibly anaphylaxis, possibly a foreign body, anything like that. Take a good listen to their heart and lungs. You can always check the belly. You can always look for accessory muscle use to kind of gauge how hard somebody is working to breathe. You can check their extremities and also look for any signs of trauma. And lastly, let's go through back pain. So what information should you ask? And what is your differential diagnosis? So the easiest would be just musculoskeletal, somebody who's lifting something heavy and pulled a muscle. Could be a nerve impingement, maybe they have sciatica. Could be constipation. Could be osteomyelitis. Anybody who is immunocompromised, struggles with IV drug use, are at increased risks of having osteomyelitis, having an epidural abscess. Also, some tuberculosis, when it migrates outside the lungs, can cause spine pain. But then you also have to think, what else is it? It may not just be the back. So what if it's an aortic dissection? That will cause back pain too. So I feel like back pain is very tricky, and you always need to be aware, because it may not just be the back, it may be the more internal structures. So running through a differential diagnosis, it's a very wide differential diagnosis, because it's not limited to just the musculoskeletal system or the bones themselves. It could be something to do with the big vessels that run throughout our body. It could be a problem in the lungs. It could be cancer. It could be metastatic lesions. It could be from age and osteoporosis. There could be issues from medications, substances, scoliosis, immunocompromised states. There could have been trauma. There could have been electrolyte abnormalities. You could have irritation of your pancreas, liver, gallbladder, kidneys, infection of any of those. That could all cause back pain. So take your great history again. Do your good physical exam. So with back pain, you definitely also want to check that all your motor pulses and sensation are intact to really make sure that there isn't an emergent need for the patient to be transported. But also it's good to be able to give that report to the hospital as a very important piece of information. So with that, that's a brief review of differential diagnoses. If you have any questions, please always reach out. And as always, please always act within your scope of practice. Follow your protocols and laws, as this lecture does not supersede your protocol, state laws, or medical command. Make sure that you're always taking a good history and physical on your patients and escalating their care as appropriate. My references.